So we'll be moving on to today's engagement.
Okay, thank you, Mr. Benga. I'll take it up from there. Our first speaker for today is Dr. Keith Landmark. He studied physics at Doha University, and then did doctoral studies at Queen's College, Oxford, in molecular biophysics, graduating in 1989. He then became a medical physicist at Brooks Hospital in Cambridge, specializing in radiotherapy and the uses of non-ionizing radiations in medicine. He became a member of the British Photodermatology Society, was a committee member, and participated in several workshops that resulted in national recommendations being published. He is currently head of radiotherapy physics at Nottingham University Hospital, NHS Trust. So he will be taking us for the next 40 minutes. Thereafter, we'll have a question and answer section. Dr. Keats, over to you. You have the floor.
Thank you very much. Thank you for the invitation. I'm just trying to, there we are. Okay. And I just check you can all see that.
Yes,
we can.
Yes, good. Okay, thank you. Well, thank you for the invitation. So, as you can tell from background, I mainly do radiotherapy physics, but I do have some expertise in photomedicine, which is basically studying light in the causes, diagnosis, and treatment of diseases. So that's what I'm going to talk about for the next half an hour, 40 minutes or so. Right. So from a physics standpoint, obviously light photons contain energy, and we can see here the various different light bands that are available. So you've got UV, which is the highest energy, from around 12.5 EV down to about 3 EV. Then visible light has 1.8 to 3.1 electron volts per photon, and the near infrared is 1.2 to 1.8 electron volts. So this allows you effectively to do chemistry. If light's absorbed, it can cause excitation in molecules, it can cause breaking of bonds, it can produce all sorts of effects. So that's why it's useful. So from a purely practical point of view, you get, when light's absorbed, it can produce either free radicals or excited states of molecules. These then can undertake chemical reactions, and chemical reactions can have biological effects, and biological effects can lead on to medical effects. And this is the same in photomedicine as potentially you can do the same in radiotherapy. If you replace light by X-rays, then basically you get exactly the same things happening. So from a sort of simple point of view, you've got a light source with a spectrum, L of lambda, where lambda's wavelength, and that's transmitted through tissue, but that is very wavelength dependent. I've got a graph of that coming up, with the peak transparency through tissue of about 750 nanometers. So that's far red light or infrared light. So obviously, as light goes through tissue, the light intensity decreases because it gets absorbed, but then the spectrum moves towards the red end with depth. So the light intensity depends on the wavelength and the depth. Biological and medical effects have something called an action spectrum, which is a plot of the efficiency of different wavelengths in powering either a specific biological or medical process. Like, for example, I think vitamin D is a natural thing that is produced by the action of sunlight on the skin, and that tends to be in a sort of near UV. Okay, so the strength of the response is proportional to convolution of the intensity with the action spectrum. So if the two spectra do not overlap, then effectively you don't get anything happening. But if they do overlap, then something can happen. So here's a plot. So this is UV light, which gets absorbed in the epidermis, the upper layers of the skin. And as you can see, through to around 7 to 900 nanometers, you get greater penetration. And then when you go into the infrared, you get less penetration. So what happens if you've got a spectrum of light like this, as you go in depth, the bluer ends, shorter wavelengths get absorbed more quickly. So you get progressively a greater proportion of red light being penetrating into that depth of the skin. And then you have an action spectrum. And if these overlap, you multiply the two values together and work out the area under the curve. And that will give you a likelihood of something happening. Now, this action spectrum can have multiple peaks, because if you're talking about light being absorbed by a particular molecule, then that can have various peaks in different parts of the spectrum. And sometimes you need oxygen as well to be around. So something called photodynamic therapy, which we'll talk about a bit later, requires oxygen to be present. So if oxygen isn't present, then that reaction won't happen. So the dosimetry is very complicated. It makes radiotherapy dosimetry look positively simple. But in practice, very few people bother with the dosimetry. They will just make sure that the amount of light being irradiating the patient's skin will stay constant. So we'll come on to that towards the end of the lecture. So here's porphyrin, which is a standard photosensitizer in photodynamic therapy. It has a big peak here in the sort of blue end of the spectrum. So you'd expect blue light to be most effective for this, but this is the light that's absorbed most in the skin. So if you're trying to treat at depth, it's the proportion of these sort of little peaks here, these little bumps here, becomes more important. So actually sometimes it's better to put in red light because the proportion of that gets down to the area you're trying to treat is much greater. So light can cause disease. So obviously sunburn is common, as is photoaging, but there are these other sort of effectively skin diseases that come up because of either a sort of photoallergic reaction to mainly UVA, but sometimes visible light. So some people can't effectively go out in the sun just because of the light brings them out in a rash. So to diagnose these, you have to put the patient through something called diagnostic photo testing. So you start off with a broad spectrum light source. So this is a xenon arc lamp, which produces basically UV through to infrared light at very high irradiances. It goes through a monochromator, so you select a wavelength, and then you put it onto the patient's skin for different amounts of time to give them different amounts of doses and watch to see what happens. In reality, what you get is that you put in different wavelengths. So you might have chosen 320, 380, 400, and give them different doses. And depending on how pink they go, you can diagnose what the cause of the disease is, and then recommend ways of treating it. So moving on to treatment, there are several common conditions treated with phototherapies. There's neonatal jaundice, there's psoriasis, and there's skin cancer. So neonatal jaundice is something that babies get just after they're born. It's quite a natural process. Their red blood cells turn over from being in the womb to being a independent living baby, which means that there's a lot of bilirubin released, which is something that is part of making up the red blood cells, is the pigmented part. So you get too much bilirubin in the blood, which in medical terms is called hyperbilirubinemia, which basically translates as too much bilirubin in the blood. And that can cause jaundice. So the baby can become yellow. And this is quite common and normally resolves quite quickly and isn't a problem. But if some babies do get too much to be healthy, and that can cause sickness in the children, so you would have to treat it. So actually the easiest way to treat it is using baby blue light. So here you've got a baby in a phototherapy unit. So this is using blue light, 460 to 490 nanometers. You can see most of the skin is exposed. This is two reasons. One, is more effective because the light, you get more light into the skin, obviously. But secondly, these are quite warm, so you have to be careful of making sure that the child doesn't overheat. Also important here is that the eyes are covered because blue light can be damaging to the vision. So basically, the blue light turns the bilirubin into something that is excretable. So and after 24, 48 hours, usually the jaundice resolves. Moving on to psoriasis. So psoriasis is a chronic non-contagious autoimmune condition of the skin, where the skin basically, it turns over quite rapidly anyway, but it becomes much more rapid. So you get build-up of plaques on the skin, so thick, inflamed, scaly patches, and sometimes that's just confined to one area. but sometimes it can be a whole body thing. So potential light treatment for these is either is basically, this is a whole body phototherapy unit. So patient is in basically a cabinet with a lot of fluorescent lights that are designed to either, oh, sorry, my fire alarms test. Okay, it's just finished. So it's either narrowband UVB, which is good at suppressing autoimmune diseases. Oh, I see somebody's got their hands up. Does that mean somebody wants to ask a question or?
No, please go ahead, Doctor.
Okay.
Yeah.
So, or you can use something called PUVA, which is a drug called Sorolin plus UVA. So the patient is given a drug a couple of hours before the treatment that renders them photosensitive. They have to wear glasses that block UV light. If they're not standard sunglasses, then they would be if they're going to be not they have to block below at least 400 nanometers. So if they're not got tinted lenses, they will end up with a yellow tint anyway because the blue light is blocked. And that is used to treat psoriasis. So they will have 2 or 3 treatments a week with ever increasing doses of UV. They start off at a level where they're given a dose that's just below the level to cause reddening of the skin. A minimum erythemal dose is called, and basically you build up from there. And last but by no means least is skin cancer. Skin cancer is often caused by UV light because it's both mutagenic. It will interact with the DNA to cause mutations, and it's also immunosuppressive. So it will stop the immune response, destroying any mutated skin cells. So the common ones really are melanoma, and then basal cell carcinomas and squamous cell carcinomas. Now there are lots of different effective treatments for these diseases. Surgery is obviously a main one. You can just surgically remove the tumor. Radiotherapy is also quite effective. There are various drugs, chemotherapies, and especially for melanoma now, immunotherapies are really important and have revolutionized the use of the treatment of melanomas. But for treatment, especially for very superficial tumors like BCCs and SCCs, then photodynamic therapy, PDT, is a standard treatment. So photodynamic therapy, so you administer a photosensitizer. Now this can be something that is ingested and goes all over, or can be something that's locally administered. The photosensitizers absorb light. This then produces reactive oxygen species, so oxygen-free radicals, for example, are produced, and that goes on and stimulates programmed cell death, so destroys the tumor. In topical PDT, you use a cream of something called ALA. So basically, it's a relatively harmless chemical that you can apply in a cream. You leave that on there for an hour or 2, It only gets absorbed where the skin is damaged, so where the tumor is, so it doesn't absorb into normal skin. The ALA is then converted by the cells into a chemical called porphyrin, which absorbs light and produces reactive oxygen species, assuming there's oxygen present. And down the bottom here is a link to some national guidelines for how to undertake photodynamic therapy in a practical setting. So at the same time we were designing this for people, I was working at Cambridge at the time, and Cambridge Veterinary School has a veterinary radiotherapy practice. So we were discussing various things with the vets there, and they described a problem they had with cats. So cats with light skin can get SCCs and BCCs in the same way as people do. It tends to be light exposed areas on either noses or ears, and here's one on the nose. From a treatment point of view, it's quite difficult because it's cartilage. Then radiotherapy has the problem that it tends to cause necrosis in that area. So there's a lot of damage there, and obviously surgery, you end up losing tissue. So we decided to trial photodynamic therapy with the cats. And so we can see here cat with lesion on nose. Then this is the cat has the ALA cream placed on the nose. You need a veterinary student to continually reapply it because the cat attempts to lick the cream off its nose, so you have to keep on applying it. And then we have an array of ultra bright LEDs, which are just commercial things that cost a few pence each. They're basically powered in a way that with a timer, so you can set a time for treatment. So after 10 minutes or 20 minutes or so, you irradiate that. So 10 days later, you can see this area looks like it's resolving, and after a couple of months, you can see basically the nose has returned to normal, and the trials proved very effective. So it can also be treated, used to treat animals as well as people. Just a brief discussion of photoimmunology. It's an unexpected effect of light is that especially UVB light can suppress the T cells in the skin. They're called the specialist cells called Langerhans cells, and they're basically designed to pick up things like infections going in through the skin. They capture these pathogens and migrate to the lymph nodes and initiate a immune response. So basically, it's the way the skin protects itself against attack from infected diseases. However, if you shine UVB light on them, they tend to become inactivated. So this is useful in the sense for treating psoriasis, because psoriasis is an autoimmune disease, so it suppresses the immunity, and hence why UVB is used in psoriasis treatment. However, it also suppresses the immune effect, so it doesn't pick up any changes in the skin. So that can be the reason why UVB is specifically a problem for induction of skin cancer. What needs exploring a bit further is that potentially it can be used in suppressing transplant rejections in graft versus host disease and the like, without the use of lots of really expensive drugs. And I think that's an area that needs exploring further, because it could be very useful in places where you don't have access to very expensive drugs. You could potentially do something relatively inexpensively with UVB light, which is relatively cheap to access. The sort of final bit of treatment is something that is relatively new, called photobiomodulation, which I personally have very little note of, but one of our consultant radiographers here, Emma Hallam, is an expert in this. So I've borrowed some slides from her to introduce you to this idea, because again, it's quite a very interesting way of treating some side effects of radiotherapy without the use of lots of drugs. So radiation-induced fibrosis can happen as a side effect of radiotherapy. So the radiotherapy, as well as destroying the tumor, can basically produce the side effects of a lot of fibrosis being produced, and this affects some patients more than others. Many patients don't have much of it, but some patients suffer really badly from it. It is quite difficult to diagnose, and it's really difficult to manage. So it does vary from patient to patient. So some patients it's doesn't cause a problem, but some patients it is really severe and long lasting. The treatments are various and not exceptionally effective, and there's no real known cure, as it were. You can put in lots of different anti-inflammatory and anti-fibrotic and antioxidant treatments, but they have limited efficacy. So it's difficult to find that. So identifying it early is quite useful, though, because we now have this photobiomodulation seems to be proving quite effective. So it's strange. It uses sort of red light in this sort of area, so it penetrates quite deeply into the tissue, and basically it interacts with some of the enzymes in the mitochondria, which is basically the cell powerhouse, which generates a lot of energy and allows increased cell repair time. It also, as well as producing this energy boost from ATP, it affects reactive oxygen species, produces nitric oxide, which is a vasodilator, so it allows the area to become better perfused, and reduces inflammation and pain. And this is proving quite effective in treating some long-standing conditions of patients. So here is an example. So this patient had a skin lymphoma called mycosis fungoides. They had some radiotherapy. There was a lesion left on their ankle, and that got some extra electron treatments. And after 10 years, this still really hadn't healed. So they had 12 sessions of red light. And that has led to much improvement over the next couple of years of the patient, the wound healing a lot better. So it's not only just used in chronic conditions like this, but as I was preparing for the lecture, I noticed in a prestigious European journal called Radiotherapy on Oncology, a group from Tehran had used it in treating oral mucositis in head and neck cancer. So patients having head and neck cancer treated can get a very sore mouth because the internal membranes of the mouth become very sore and inflamed. But using they did a prospective double-blind self-controlled clinical trial on the use of PBM, and you can see that the patients who received it healed a lot quicker than the ones that didn't. So this again shows that it's very, this is an acute side effect of radiotherapy, and it shows that something that is relatively inexpensive can provide a good way of treating these things. Other therapies are not as effective at all, so it's worth bearing in mind. And as I say, this was done in Tehran; it wasn't done in a high-income country. So to finish off, we need to move on really to the measurement of light, because that's the sort of physics role. Apart from potentially designing equipment that can provide the irradiation, the question is can we make sure we know what's coming out? Because it's important to ensure that the treatments are both safe and effective. So you need to, first of all, to choose a detector. And it really needs to be chosen for the specific role. So if you're trying to measure UVB light, you don't entirely want it to be, it needs to be just responsive to UVB light rather than blue light or the like. So each type of detector will have its own spectral response, and that really needs to be matched to the light source that you're measuring. Also, the spatial response is important because many of these illuminators either are very directional or not, and you can have, if you're in a phototherapy cabinet, then the light is coming from all directions. So it needs to be able to respond from those. So there are various types of detectors. The most broadband are these thermal detectors because effectively they turn the light into heat and use that, and so thermopiles and the like are very useful for having a detector that can be used across many wavelengths. Photomultipliers tend to be a bit too sensitive unless you're trying to measure very low light. The most practical things are photodiodes, really. So those are the ones that tend to be used in the clinic. So this is what's known as the cosine rule. So if you've got a beam of light irradiating a surface with intensity E0, if you bring it in from the side, then the light gets spread over a larger area, which depends on the cosine of the angle of incidence. So you need to make sure that your detector responds in that way. So often you need to put a diffuser on top. So here's a picture of a detector, and this white area here is a diffuser. It can be almost like a ping pong ball or half a ping pong ball that just ensures that the light responds in an appropriate way. And of course, calibration is obviously the really important side. So light meters must be calibrated for the purpose they're used for. Something called a spectral radiometer is really useful in terms of calibration, because that's a detector where you basically it'll split the light up into its various wavelengths and then scan through those and measure the intensity at particular wavelengths. But they're very difficult to use in a clinical setting. So it's often the best thing to do is to buy something that has been calibrated for a particular purpose. So you can go and buy something that is designed for detecting UVB light with a particular types of lamps. So they need to be calibrated for the type of lamp that you're actually using. Otherwise, the answer will basically be wrong. And there's a link here to a company that does that sort of thing. So a bit of a case study. So if you've got a patient stood in a photo cabinet, so like we saw earlier, basically there's an array of fluorescent tubes around the slide. There's a built-in detector to control the exposure, but this is just behind one of the tubes. So that needs calibration. And actually the presence of the patient changes the calibration. So here you are, yeah. Behind one of these, there will be a detector. So it's not safe to go and stand in the cabinet because the UV light will cause basically give you sunburn. So you could put some sort of phantom in there. You could take a tailor's dummy and put it in there, or you can work out a calibration factor, a correction factor for the presence of the patient, and just put a calibrated photodetector on a stand in the middle here, and then apply a correction factor to then use that to calibrate the cabinet. So that needs doing relatively frequently because the output of the tubes do change over time. So to summarize, light interacting with tissue can cause a number of different effects. Some of these will cause diseases and can be characterized using phototesting. With the use of suitable sensitizers, light can also be used to treat diseases. But in all cases, it's really important to measure the intensity of the light so that you maintain a proper and safe therapeutic effect. Okay, I shall stop there. Stop sharing. There we are. So happy to answer questions.
Thank you, Dr. Keats, for that wonderful presentation. The take-home for me is that photodynamic therapy can be used for treating skin conditions and also for neonatal jaundice. But there's one question I would like to ask you, Dr. Keats. Is this peculiar to just Caucasians or for all skin colors?
Well, that is a very, very good question, because obviously skin pigmentation does have a great effect on the what light does get into the tissue. So I think the answer is no. It can be used to treat lots of different skin colors. The problem being is that quite a lot of the research done in this has only really been done with Caucasian people, and that's one of the problems of clinical trials. Lots of clinical trials are basically done on young white males. And the same is true of drugs in general. It can be quite difficult, and detecting erythema in patients with darker skins is one of the problems we struggle with in the UK, is because obviously we have a mixed population with lots of different skin tones, and we're quite good at spotting erythema in the white population because they turn pink and red and it becomes obvious. And there's a fair amount of work trying to go on to develop ways of doing that with patients with more pigmented skin. So I think these things work, but you will have to take into account the fact that melanin is very good at absorbing UV rays, so some of those might be less effective in patients with more pigmented skin. But as you can see, the Iranian population, although not very dark, are photobiomodulation, because it's red light, it's probably less affected by skin tone than other forms.
Thank you, Dr. Kit. We also have another question here from Aliu Abdulaziz Bale. And the question goes, in regards to photoimmunology, is everyday sunlight silently weakening our immune defenses over time?
That's a very good question, and the answer is sort of yes. Obviously, we've evolved with the presence of UV light, and like we've evolved with the presence of natural background radiation. So there is a so basically we've evolved with it there, but it is worth bearing in mind that UV radiation will weaken the skin's immune reactions, not deeper, but so it is a problem with the skin cancer starting, because it's suppressed the immune response to the changes in the skin. But it's quite useful in terms of in terms of treating autoimmune diseases of the skin. So it's a bit of a balance.
Thank you, sir. We also have another question from just a minute. Just a minute.
So
Yes, I'm trying to assess the question. Okay, from Dauda Boluch, he said, please, what is radiation effects absorbed by commercial drivers? I mean, is there potential effects on the drivers? That is from Dauda Umar Boluch.
yes,
I don't understand the question.
yeah, I'm trying.
Okay, just a minute. Let me go back to the question.
What commercial drivers does he,
Yes,
what are you
I
trying to
guess it
say?
should be the effect of maybe soil rates on commercial drivers.
Okay.
Okay, so I mean, are we worried about commercial drivers? I mean, is there potential effect on the
Maybe
driver?
because they're always in the sun. So generally,
Oh, okay.
yeah, probably that's what
So
he's trying to say. Yeah.
yeah, so I mean, you do get, if if people are driving for a living, if you've got the window open, then the side that is the sun is coming in from, the grass is very good at blocking UV. So potentially, yeah, if you've got the windows open, then that side will get more potentially will get more sun and potentially more sunburn or whatever.
Okay, thank you, Dr. Kit. From Blessing Tony, she asks, does sunscreen really protect us entirely from sunburn, or is
Mhm.
it really an effective method to protect our skin from sunburn? That is from Blessing Tony.
Yes, so I think the simple answer is yes, but it has to be applied appropriately. Um, so basically, all it is doing is blocking the UV getting to your skin, and there are some chemicals in there that will block UVB and will effectively protect against sunburn, and there are some that are called blocking UVA, which tends to be more of a skin aging effect. So many cosmetic products that say, anti-aging cream basically have a UVA sunscreen in them because it does stop the skin aging due to the UVA. It doesn't do anything else. So it is effective, but you have to apply enough of it, and you have to apply it often enough so that if it's got washed off or whatever, it needs reapplying. So it is very effective, but it does have to be used properly.
Okay, thank you. We still have one more question from OJ Dominion. Um, he asked, concerning the use of cosmetics and beauty products, what advice can you give to be able to prevent us from skin issues?
Uh it's a very interesting one because sometimes some products can irritate the skin. Um, and so as I was saying with the anti-aging creams, they often they're allowed to be called that because they've got a UVA protective sunscreen in them. Um, I think some chemicals with some people can react to light and cause problems. So I think it depends very much on a person by person basis.
Okay. A question just came in. If sunlight, what's a healer? Um, if sunlight both a healer and a silent threat, how do we balance? Oh, sorry. Let me get back to the question. Okay, if sunlight is both a healer and a silent threat, how do we balance its benefit, vitamin D, against its immune risk?
I think the immune risk is quite small. But it's just be worth being aware that it does exist because there's nothing much you can do to stop it. You can wear sunscreens. Um, I think it depends very much on your individual sensitivity. Um, in the UK, we're often told to take um, vitamin D supplements in the winter because even with very light skins, the amount of UV is not enough to give us enough vitamin D. Um, those with more pigmented skins are often encouraged to take vitamin D supplements all the time. When you get into more, equatorial regions, then perhaps the balance is more, there's too much UV, so you might want to protect against that. But some of you are lucky enough to have UV protection built in.
Okay, then thank you, Dr. Kate. Marian Abubakar, she has a question. Please, I have a brother suffering from vitiligo. At some point, a dermatologist asked him to be receiving vitamin D directly from the sun, but no positive effect for years. After doctor asks him to completely avoid the sun rays, what advice can you give based on this?
Oh, you need to talk to a medical doctor rather than to a physicist. I know vitiligo in the UK can be treated with UV lights, phototherapy cabinets to encourage pigmentation. I think it's one of those things where you need to take medical advice. It's not entirely, and it is quite a difficult disease to treat. As I say, in the UK, it is often treated using UV to encourage pigmentation, but I don't know how effective it is.
Okay, then from Dr. Adebayo Abe, see how many times can skin sore or wound that likely to form squamous carcinoma in
Yeah.
albino be treated?
So it depends on the sort of treatment that you're using. So if you're using photodynamic therapy, you can repeat it quite often. But if it keeps on recurring, you probably want surgery. Radiotherapy, reirradiation is often discouraged. So yeah, so it's quite so it depends on the sort of treatment, but photodynamic therapy can be treated multiple times, but I think if you're getting something that is continually recurring, you might want to think about surgery.
Okay. So from Jane Francis, she asks, please can photosensitizers be produced from local materials? Are there improved ways in areas where they are limited?
That's a good question. I think some of them can be quite common. So I think you need to find a chemist and discuss which ones you want and how you can produce them, whether they're something that you've got naturally occurring or whether some simple chemistry can be done. I think it depends on what you're trying to produce. Some of them are relatively quite cheap and easy to produce.
Okay, this will be our last question for this segment. Just a minute. Okay. Okay. What balance effect does radiation have on Earth? That will be the last question for this segment.
I guess it depends a bit on what sort of radiation. Because ionizing radiation is obviously really quite dangerous. Um, and different types of visible light can have a whole range of different effects, as we've seen. So I'm not sure there's one answer to that question.
Dr. Keith, can I rephrase the question?
Yeah.
I remember there was when I was a student, someone gave a seminar presentation on the benefits of radiation, ionizing radiation. So in your over 30 years of experience, have you ever had to be in such an environment where that has been argued? Because people are of the opinion that there are some benefits. So
Ah, Yeah, that's an interesting one, is that I think from an ionizing radiation point of view, um the linear no threshold model is the one that is internationally respected, and so even low doses of radiation down to very low levels, I don't think have ever actually shown any positive health effects. There are studies of people who have had, X-rays or whatever over many years, and they're still showing things like excess cancers and the like. So I think avoiding uh, ionizing radiation where entirely possible should be encouraged, because I don't think there are any proven positive health benefits. I think there was a study once showing that radiologists lived longer than other people. But then again, they're radiologists and they're not necessarily they have a certain socioeconomic standing, and
Oh,
if you're relatively rich, you tend to have better health than people who are relatively poor.
okay.
So it might be a little problematic in believing that thing.
All right. Okay. Thank you very much.
I mean, there's the attitude to ionizing radiation in the UK is basically, the legislation says that any of it is dangerous, so it should be minimized as far as possible. And we have lots of legislation saying with quite tight limits, and lots of training to say stay away.
All right. Thank you.
Thank you, Dr. Kate, for your time.
Okay.
Thank you.
Well, enjoy the rest of your school. It's been nice.
Thank
And
you.
thank you.
Thank you.
Thank you
Bye.
so much, Dr. Keith. Thank you very much.